in medical school, there's a lot of emphasis on the dyad, right? You and the patient, right? And that decisions that you make are critical. And it's true, they are critical for your patient, but they also can reinforce like systemic inequities if you're not aware of, what your patient is experiencing like in their everyday lives, right? What is happening in their communities. And so I always say that, clinicians, a lot of times we think of, when we're in the room with our patients, it's just the two of us. But I always think there are all these other people in the room. There's the family, the community, your employers, right? So there's all these other people in the room that actually impact the quality of life that your patient is having.
You're listening to the Health Disparities Podcast for Movement is Life. I'm Dr. Mary O'Connor, Chair of the Board of Movement is Life and Co-Founder and Chief Medical Officer of Vori Health.
And I'm Dr. Hadiya Green, Steering Committee member, founder of Healthy Healing Community. We're excited to introduce our guest for today's episode. Dr. Uché Blackstock is an author, sought-after speaker on racism in medicine, and founder and CEO of Advancing Health Equity. She's a former associate professor in the Department of Emergency Medicine and the former faculty director for recruitment, retention, and inclusion at NYU School of Medicine.
Dr. Blackstock is also the author of the book, Legacy, A Black Physician Reckons with Racism in Medicine. Dr. Blackstock, welcome to the Health Disparities Podcast. We're just so excited to have you here.
Thank you so much for having me. I'm excited to be here.
Great. So before we dive into the conversation with Dr. Blackstock, I just want to put a plug in for our upcoming Movement is Life annual summit. The theme of our summit this year is Combating Health Disparities, the Power of Movement in Community. The conference will be in Washington, D.C. on Friday, November 14th, and it's really an incredible event, bringing together stakeholders from diverse backgrounds to discuss the challenges that we're facing with health disparities and to drive to actionable solutions. So we hope you can join us. For the summit, you can visit our website, movementislifecommunity.org, for all the details. Okay, Dr. Blackstock, I'd love for you to introduce yourself to our audience because they may not know a lot about you.
Okay. So other than the bio, so I'm an emergency medicine physician by training. I was in academic medicine for about 10 years. And then, had several experiences, as a Black woman physician, also, as someone who's cared for a diverse patient population, where I recognized, this was like in 2019, I realized that I wanted to really help organizations think about how to operationalize equity. And what that looked like in leadership, operations, care, and strategy. And I wanted to help them move from aspiration to action in terms of closing the gap in racial health inequity. So I founded Advancing Health Equity, which is my strategic consulting firm. And that's where I do a lot of my work. I no longer practice clinically, but just as I left my job in 2019, we know what happened in 2020, and I was working in Brooklyn, New York. I was still working clinically then. And we were the epicenter. And, I was obviously in shock about what happened. But within the first few days, I said, I have to ring the alarm. I really have to write about what I'm seeing. And that I think that really it's going to be Black, brown, and marginalized communities that are going to be most disproportionately impacted by this virus. So I became one of the first voices in the pandemic to really talk about racial health inequities and to bring attention to it. And, I would say that, and that was that was the beginning of really, sort of like using my platform as a health equity advocate. I became an MSNBC medical contributor, and I honestly used that role in order to communicate all of this, like dynamically changing information, so a lot of information to our communities in a way that they could understand it and be informed and make informed decisions about their care. And then I had the opportunity to write my book, Legacy, A Black Physician Reckons with Racism in Medicine, which came out last January 2024, was an instant New York Times bestseller. But I think that speaks to really how much people really care about health equity, about health disparities, and really wanting to find ways that, in 2024 and 2025, where we have so much wonderful technology, research, and innovation, like to think about why some of these disparities are even worsening, right? So, I really wanted to use that book to bring people in.
Thank you so much, Dr. Blackstock. And we talked about your accolades and the immense amount of work that you've done and put into this area, which is only enriched by your personal background. I understand that growing up, you and your twin sister, Oni, were surrounded by Black women physicians,
Yes.
your mother being one of them. But your mother, when she was a child, had the opposite experience. So you write that she rarely saw a physician as a child, let alone a Black one. So tell us about your childhood and how your life growing up ultimately led you to pursue medicine as a career for yourself.
Yeah, thank you for that question. I always talk about, being a physician is very, very personal, right? Because it's a generational theme in my family. I'm blessed to be able to say that, right? But, my mother's upbringing, as you allude to, is very, very different than mine. My mom, was born actually here in Brooklyn, where I live, about 15 minutes from where I am right now. But, born into poverty and, raised on public assistance. To a single mom, she had 5 other siblings and really had a very, very difficult life, very, very challenging. And I think she just had like a curiosity about her, and she loved science, and she had a very strong work ethic, and there was luck and fortune and all of that. And she ended up at Brooklyn College, the first person in her family to finish college. And there she actually had a chemistry professor, Dr. Dillard, who saw her potential, and he was a Black man, and said, I think you should apply to medical school. I see that potential in you to become a physician, encouraged her to apply to medical school. She got into all her med schools, and then ended up at Harvard Medical School. And of course, there she felt like a fish out of water, because there were so many of her fellow students whose parents had written the textbooks they were using, who had won Nobel Prizes. But she knew that she was there for a reason. She was there because she wanted to come back to her community and practice and work in service to her community. And so that's what she did after she graduated. She returned to Brooklyn and really worked with a community of Black physicians that actually lived in the same areas where they practiced, right? So I think that was also very, very special. But growing up, because I had this exposure, I tell people when I was a little girl, I thought that most physicians were Black women. I didn't realize that, they only represent 3% of all physicians in the United States, but I had this very, interesting, unique perspective that I'm very, very grateful for, because it enabled me to see that, this was something I could be, but also these women were just such wonderful role models, because they were doing community-based work, around health equity at a time when we weren't even talking about health equities, the 80s, right? So they were really thinking about what are the services, what are the approaches we need to keep communities healthy. And so that's the exposure that I had that really informs a lot of the work and advocacy I do now.
You mentioned the number of Black women physicians, and we know that even today, the number of Black physicians in the United States remains stubbornly low. Only about 5% of all U.S. physicians identify as Black, although Black people make up about 13% of the population. In your book, you dive into some of the reasons for this. So share with our audience your thoughts about the Flexner Report, which was that landmark report in U.S. medical history that had such an impact on the need for greater diversity in the medical workforce.
Yes. Yeah, I thought it was so important to be able to tell this part of the story in legacy, because I think people, they look at the numbers and say, oh, really less than 6% of all physicians in the US are Black. Like, is there something wrong with Black people? Like, why aren't they getting the job done? Come on, just study. And I think it's really important to understand that, when we see the numbers that we see, especially in this country, we really have to look back historically at practices and policies that have impacted the number of the diversity of our healthcare workforce. And so the Flexner Report, really important report that, I didn't even learn about until I was a practicing physician. But the impact has had a domino effect for decades. So in 1910, American Medical Association and Carnegie Foundation, they commissioned Abraham Flexner, a white education specialist, to go around to all 155 U.S. medical and Canadian medical schools to really assess them against the gold standard of Western European schools in the U.S., Johns Hopkins, which was the gold standard. And so they were looking at, what kind of admissions criteria were they using? What were the laboratories like? What was the percentage of physician scientists on faculty? And based on that report, he made recommendations about whether or not a school should remain open or closed. And so that report looked at closure of actually predominantly white institutions as well. But the issue was also that at the time, in 1910, there were only 7 historically Black medical schools. And at that time, they were the ones educating most of the Black doctors, because Black doctors were not allowed to be admitted into predominantly white schools. And so, that report closed 5 out of 7 of the medical schools, leaving behind Howard and Meharry. And so it's estimated, and so I also just wanted to say that, these schools, these historically Black medical schools, they were probably operating with a fraction of the endowment and a fraction of the resources that predominantly white schools were, because of the legacy of slavery, right? But who's to say, objectively, that they were graduating, physicians that were, delivering a lesser quality of care, right? But the impact that it's had is that, there was a report in 2020 in the Journal of American Medical Association, interestingly, that estimated that if those 5 Black medical schools that were closed in 1910 had remained open, they would have educated between 25,000 and 35,000 Black physicians. And that number is so incredibly staggering, because you think about tens of thousands of physicians, the impact they could have made on patient care, the impact they could have made on research, and that we really are seeing, in the numbers today in 2025, the impact of that report.
So I want to shift a little bit and get into the policies that contribute to some of these differences that you eloquently outlined in the Flexner Report. So let's get into some of the ways that racist policies have contributed not only to the underrepresentation of Black physicians, but the rampant racial health disparities we see. In these conversations around disparities and inequities, we often hear about redlining and the lasting impact on communities that it has had. You actually grew up in the Crown Heights area of Brooklyn, New York. So that clearly was also affected by redlining policies. How did redlining personally affect your family and your community?
Yeah, what's so interesting is that I didn't recognize how much redlining had impacted my community, again, until I was a practicing physician. But growing up, first of all, I loved my neighborhood. I loved my neighbors. We looked out for each other. But I also appreciated how my neighborhood was very different from neighborhoods only like a 5-minute drive away, right? I noticed that we didn't have a grocery store. I noticed that we didn't have a lot of green space, right? I knew that my parents did not feel comfortable with the quality of education of the public schools in our neighborhood, right? And it wasn't until I was a practicing physician really learning about how do health disparities evolve, right? Learning about the impact of policies from the 1930s, right? Where neighborhoods were assigned grades, A, B, C, or D, based on who lived in those neighborhoods. And most of that determination was based on the racial and ethnic composition of who lived in those neighborhoods. So if they were minoritized populations or immigrant communities, purely based on that, they were not, if they applied for a mortgage or mortgage-backed insurance, they were very unlikely to qualify just because of where they lived, not because of anything else. And so when I talk to students about this, I say to them, what happens to a neighborhood where people are not able to own property, right? What happens to that neighborhood? So people are renting. We know that they're not able to accumulate or generational wealth. We know that property taxes go towards funding schools. So there's a low tax base, right? And that impacts the quality of education. We know that if people don't have disposable income, businesses aren't going to come to establish themselves in that neighborhood. And if businesses don't come, then jobs don't come. And so it's all interconnected. And I tell them it's interesting when you look at the maps of redlined areas from the 1930s, and if a neighborhood hasn't been gentrified, those are the same neighborhoods today where we see some of the worst health outcomes. And that's one of the reasons why there could be like a 20-year age gap, right, in terms of life expectancy between two neighborhoods that are really like adjacent to each other, but the quality of life in that neighborhood, when we talk about the social determinants of health, are vastly different. And that impacts how long people live for, how healthy they are. And so for me, it's really important that health professionals understand this, like not when they're practicing, they understand it, during their education and training, because it really does influence how you care for your patients and the perspective that you have.
So, Uché, let me follow up on that, because you talk about in your book, stunning omissions and flaws in the education that you received, and that the information that was imparted to you and other students in the classrooms and through the hospital was presented as factual data and research driven, but it didn't lack kind of a broader context in terms of socioeconomic or socio-political. So can you tell us a little bit more about that and the direction that you think we need to move so that our clinicians, our healthcare professionals, can be better educated and better equipped to care for people that aren't necessarily just don't look like them?
Right. It's so interesting. There's this pyramid that I use a lot in my slide presentations. It's from the CDC, but it's a pyramid that kind of breaks down the impact on health of different interactions and that patients have, like either with like systems or with health professionals. And at the very top of the pyramid, which is like the least impact on health, is actually, the clinical interventions that we do. And what's at the base of the pyramid is systems. So it was like housing, right? Education or systems, of racism, right? That has an impact. And so what we know is that about 80% of what determines, over 80% of what determines how healthy someone is, really is systemic, is really beyond their control. And I think what's interesting is that in medical school, there's a lot of emphasis on the dyad, right? You and the patient, right? And that decisions that you make are critical. And it's true, they are critical for your patient, but they also can reinforce like systemic inequities if you're not aware of, what your patient is experiencing, like in their everyday lives, right? What is happening in their communities. And so I always say that, clinicians, a lot of times we think of, when we're in the room with our patients, it's just the two of us. But I always think there are all these other people in the room. There's the family, the community, your employers, right? So there's all these other people in the room that actually impact the quality of life that your patient is having. So I was even thinking about, for example, like even like smoking. Like someone can not be a smoker, right? But if they are working in an environment where they're surrounded by secondhand smoke, right? And that's the only job that they can have. They have very little sort of autonomy to decide, whether or not, I want to be exposed to this. So these are things that we have to think about. Obviously think about, air pollution and, environmental racism, occurring more often in communities of color or marginalized communities. So I think we need to have, of course we can tell our patients, yes, be careful about smoking, try not to drink so much. All of that, sure makes a difference, but what makes it a bigger difference is really to understand what's happening in our patients' communities.
I really appreciate that you brought up the social determinants of health, and you and Mary touched on the political determinants of health, as Daniel Dawes refers to them, because I think that there is a growing awareness that you mentioned when your book did so well, so quickly off the shelf, and interest and efforts on the part of healthcare providers to start to sew in where there are these holes in the net. And I think one of the holes in the net are the health and well-being of actual Black healthcare providers. And as a Black healthcare provider myself, and one who understands that you are under immense, you're under the same influences and impacts that your patients are undergoing. And there's this undercurrent of silent suffering among many of us that starts from when we are in school, as you mentioned, like that it's not okay to wait till you're practicing to get this information, but when you're in school. So may you tell us about more of the subtle and sometimes not so subtle ways that racism permeates or even upholds the medical school education as we currently know it?
Yeah, and it's so interesting because I think at the end of my book, I talk about whether or not I would want I have two boys, two sons, 8 and 10, if I'd want them to go into medicine. And I say I have really serious concerns about that because, as eventually two Black men, I have concerns about the experiences that they would have as students, as residents, as practicing physicians, because based on what I've seen, and obviously as a mama, I want to keep them safe, and I don't know if that environment is safe enough for my children, just based on what I've experienced and what I've seen. And so, I always say that, medicine, healthcare is just like a microcosm of the rest of society. It's not like, yes, there may be people within medicine and healthcare who are more altruistic or want to help people. But the fact is that if you've been socialized like in this society, right, whether it's intentional or unintentional, you have absorbed a lot of the cultural messaging that is around us, that is based in stereotypes, that's based in myths, right? And, we see that, even coming up in medical education where certain things like kidney function, right? Like we're for kidney function, I thought, because based on what was on the electronic medical record and what I was taught in school, that there were actual differences between how Black people's kidneys functions and non-Black people's kidneys function, right? And here we are, like years later, finding out that that distinction actually cost people their lives. They caused people to be deprioritized on the kidney transplant list. Like the National Kidney Foundation literally had to go back, reprioritize 14,000 Black patients because of this race correction factor that's used for kidney function, that's based on this myth that Black people have higher muscle mass, and that's related to creatinine, and that's related to GFR. So it's so dangerous how a lot of these stereotypes and myths get promoted, and then they get internalized, by clinicians. And we're just saying, okay, we're just doing our thing. And, or even like the pulse oximeters, the pulse oximeter issue with people with melanated skin, so Black, Hispanic, Asian, how actually FDA has known for over 30 years. But it wasn't until during the early parts of the pandemic where people were doing studies that showed that there were patients that were not getting the medications that they needed because the pulse oximeter was giving a different value, was saying, actually, no, your oxygen is fine, even though the patient may have been saying, I'm not feeling fine. And so there are all of these ways, I think, that our system has really betrayed Black patients and other patients of color. And so that's why, like, when we talk about medical mistrust, I get really it's a cringe to me, because it's almost like you're asking people, like, why would you feel this way? It's almost surprising. It's like, no, why wouldn't you feel this way? And what do institutions and systems have to do to engender that trust in the first place?
I'm going to follow along that theme because, I think a lot of the times we think of physicians as being very objective. We're trained to follow the evidence, right? We're supposed to be scientists, and not be biased.
Right.
But we know that we all have blind spots. I mean, it's part of the human condition to have bias. Just, that's part of who we are. And of course, recognizing those biases, especially in medicine, that we
Yes.
bring into the patient conversation or encounter,
Yes.
and how we can control them or work to mitigate those biases, I think is really important. So do you feel that there's a growing awareness about implicit bias now? At least, do you think we're moving in the right direction? And do we need to acknowledge more of that?
So it's interesting. I when I hear unconscious bias, I always want to make sure I make the point to people that, even though it's something that's unconscious or involuntary, we know that it still is incredibly harmful, right? And so just because it may not be explicit, it may be implicit, doesn't, we know that it has, very negative impacts on patients. And I think that, we saw in 2020, 2021, a lot of work being done around unconscious bias in healthcare settings. Obviously what's happening right now politically in this moment, we're actually seeing a lawsuit against California Medical Board for requiring implicit bias training for California physicians, right? So we're seeing a movement that is almost like erasing or negating that this actually impacts patient care. So this is something that, we definitely still have to talk about. I'm also not one to believe that one or two trainings is going to get rid of someone's unconscious bias. I actually personally think that we need checks and balances in our systems. So for example, we saw with the opioid epidemic that white patients were actually being overprescribed pain medications, and Black patients were being underprescribed. So we need the systems to keep track of that. We need to see how our health systems going to hold themselves accountable if they see these disparities. What are they going to do in real time? I once worked with an emergency department who they found that their Black patients were waiting 80 minutes longer to get admitted to the hospital, right? And so, of course, all the providers are like, "Oh no, I don't know why that would happen." Okay, fine, you don't know why that would happen, but we're going to make sure that we actually have a dashboard. We have an internal dashboard that shows how you're doing compared to what the standard should be, right? We're going to have, reminders in electronic medical record, every 20 minutes to say, hey, you got to disposition this patient, right? What's your disposition? Are they staying or are they going? So I do think that, these internal biases that people hold, because it's everywhere, because they get it from their parents, they get it from school, they get it from television. Really what we need, yes, self-reflection is great, but we also need to have processes in place that can mitigate these biases that are not dependent on individuals, that are dependent on systems.
I'll point out one other example, because I think sometimes we think of unconscious bias as only being related to race. And that is, and you and I, we know, all of us know that's completely untrue, right?
Everything, yeah.
And sometimes if I'm at a meeting and I'm giving a presentation to 500 orthopedic surgeons, and I say, okay, I want everyone to raise their hand that wants to operate and do a knee replacement or a hip replacement on the patient who's morbidly obese. Okay, be honest, raise your hand, right? And of course, no one raises their hand. Why? Because it is physically much harder. It's physically much more taxing for the surgeon to do that surgery on somebody who's that large. The post-operative risks are higher. They're likely going to need to stay in the hospital. I mean, there's just all these factors that come into play that that I think bias the surgeons consciously or unconsciously.
Mhm.
When that patient comes into the exam room, you are more likely to say, no, I don't think surgery is the right next step for you, right?
Right. Yeah.
Yeah. And then we also know that, of course, obesity prevalence is different depending on sex,
Right.
race, ethnicity. So yes, it's a huge issue.
Yeah.
Hadiya.
Well, it looks like we are wrapping up our time, so this will be the last question or two. We understand that you yourself have gone through experiences that could contribute to medical mistrust, even to you as a now physician. You have a personal experience that you talk about,
Yes.
and where you were misdiagnosed and left
Yeah.
understanding what it feels like to be that patient at the mercy of the white medical establishment, so to speak. So
Yeah.
can you tell us about that?
Yes. As a medical student, first year medical student, I had to go to the ER 3 times to be properly diagnosed with appendicitis over the course of a week. And I was, presented with nausea, vomiting, belly pain. And during a few of those visits, I was really, of course, I'm a young woman of childbearing age, definitely going to ask my sexual history, but I was really like prodded and interrogated about that. I was told also I didn't seem to be in that much pain. So I was sent home twice from the ER. And by the third time I came back, my appendix had perforated. And I had to have an open appendectomy because there was so much pus. Typically it's done laparoscopically with the cameras. And then I developed an intra-abdominal abscess. So I had to be out of school for 4 weeks. So, we talk about these sort of biases. We know that the ultimate impact they have on patients could be misdiagnoses, could be delayed diagnoses, it could be harm, and then sometimes even deaths to people, right? Just it can be bad. So, I think definitely being a young Black woman, there were things that happened in those interactions that I reflected back on. I didn't realize in the moment, but later on, I look back and I'm like, that was not fair. That was not appropriate. Yeah. But yes. I learned that lesson. That was such a huge lesson for me. And really one of the biggest lessons from that was really just listen to your patients. Listen to your patients. It doesn't seem like rocket science, but if you truly listened, they tell you, they 99% of what's happening, right? They can, you have the diagnosis there and you can treat them properly.
I think that is absolutely the most critical thing. If we listen to our patients, it's going to engender trust.
Yeah.
And trust is essential to have a positive relationship where the healthcare professional can actually partner with that individual to help them on a journey towards better health. So, okay, we're wrapping up. Dr. Uché Blackstock is author of the book Legacy: A Black Physician Reckons with Racism in Medicine. She's also a sought-after speaker on racism in medicine and founder and CEO of Advancing Health Equity. Dr. Blackstock, thank you so much for joining us today on the Health Disparities Podcast.
Thank you so much for having me. I had a great time.
Our pleasure. That brings us to the end of another episode of the Health Disparities Podcast for Movement is Life. I'm Dr. Mary O'Connor.
And I'm Dr. Hadiya Green. Until next time, be safe and be well.